Welcome to our sixth lecture in our radiology course. Bismillah wa salatu wa salam ala Rasulillah. Starting with plain terms of the abdomen. Our lecture map for today, what to look for, starting with obstruction, bowel obstruction, series, then the distribution of normal gas pattern and abnormal gas pattern, and means, which is some cases you should know, then extraluminal free air, soft tissue masses, and calcification. Starting with what to examine, first the distribution of gas pattern. We have certain viscous structures like the stomach and small bowel and large bowel, and each organ has a certain gas distribution pattern of each organ. Then extraluminal air or free air in diaphragm or in between the organs have certain signs. Soft tissue masses, calcification. Starting with normal gas pattern, stomach, we can see normal gas bubble in the stomach. Normally, it is always normally to appear. Small bowel, there are 2 or 3 lobes of long-distended bowel. The normal diameter of the small bowel, 2.5 centimeter. The large bowel, normal air or normal gas pattern of the large bowel appear in rectum or sigmoid, almost always there, and even the rest of the colon. Here we have, this is the gas in stomach. In the center, we have gas in few lobes of the small bowel, because the small bowel, jejunum and ileum and the duodenum in the center of the stomach. And in the periphery of the image, we have, this is the cecum, this is the ascending colon, transverse colon, and descending colon and sigmoid, and this is the rectum. So these are normal gas pattern in abdominal tract. After the distribution of gas, we have normal fluid levels. The stomach always, except supine films, isn't adherent, but in the stomach we have a single air fluid level between the fundus and the rest of the stomach. The small bowel, the normal air fluid level in the small bowel is 2 to 3 levels in number. Large bowel, there is no any single air fluid level in the large bowel. So it means the presence of air fluid level in the large bowel means abnormality. Here we have the stomach has the fundus, and air fluid level means that there is the superior area has got air and the inferior area has got fluid with interface between this air and fluid. In the small bowel, like area like here, in the center of the image, air fluid level in small bowel appear in erect abdomen because of the effect of the gravity on the fluid. Regarding how to differentiate between large and small bowel in different images, large bowel always peripheral. These are the large bowel, peripheral, and it has hastral markings and doesn't extend from wall to wall. This is hysterectomy. Okay, this looks like brackets, continuous brackets. This is the restoration of the colon. Here in small bowel, we don't have this pattern of distribution because it's only characteristic for large bowel. Small bowel, here in the center, is central in location and have valvular teeth extend across the lumen, maximum diameter of 2. Regarding the maximum diameter of large bowel, we have the cecum up to 9, we have the rest of colon up to 6, so we have a certain rule called 3 for small bowel up to 3, 9 for the cecum, and 6 for rest of colon. This is the 396 rule. When assessing the bowel or the abdominal radiograph, when we are assessing abdominal radiograph for obstruction, we need to request for the patient a supine radiograph, meaning the patient is standing upward, prone or lateral, rectum, erect or left decubitus film, and chest erect or supine to visualize the distribution of air fluid levels and extension of the bowel and colon. Looking for scout film for gas pattern, the distribution of gas pattern, any calcification, any soft tissue masses, because it can lead to obstruction and causing acute abdomen, which is an emergency. Then we have to look for gas in rectum or sigmoid, because absence of gas in rectum or sigmoid always accompany the intestinal obstruction or large intestinal obstruction. Gas in ascending and descending colon, the normal radiograph, we have the presence of normal gas distribution in ascending, but here the descending is absent and few in the ascending colon. And on lateral view, we see the rectum to assess the presence of air within it. In erect film, we look for air, free air under the diaphragm, also air fluid level, as we counted before. A single air fluid level is normal for stomach. From 2 to 3 fluid levels is normal for small bowel, and the large bowel we shouldn't see any air fluid level. Then left lateral cubitus film. In left lateral cubitus view, if you notice here, we have an air fluid level in the lateral decubitus film. This is the air, most probably in the cecum, and this is the fluid. This is the density of air, and this is the line in between the air, the gas, and the fluid, which is indicated for intestinal obstruction. In erect, chest radiograph, as we seen before in the curriculum of the chest, you have to notice the presence of free air under the diaphragm, pneumonia, and the presence and the pleural effusion. Abnormal gas patterns can indicate mechanical obstruction or gallstone ileus or functional ileus. When we speak about functional, mean that the function or the nerve supply to the ileum is cut. Localization, sentinel lobes, generalized adynamic ileus, mechanical obstruction could be in small bowel obstruction or cases of large bowel obstruction. SPO stands for small bowel obstruction. LPO stands for large bowel obstruction. The laws of the gut, lobes proximal to an obstruction will be dilated. For example, if we have a pipe and we have some area where there is obstruction in this pipe, the area proximal to the obstruction before the obstruction is always dilated, and the area after the obstruction is always collapsed. Lobes distal to an obstruction will be decompressed or airless, air-free or airless. Most dilated lobes will either be distended to start, bowel just proximal to the obstruction. They are dilated. We have air in rectum or sigmoid localized ileus. Yes, we can visualize air in the rectum and sigmoid, air in small bowel from 2 to 3 distended lobes, air in large bowel, air in rectum or sigmoid visualized. In cases, this is localized ileus. That means there is a local area in the ileum isn't innervated. We can visualize some normal air in the rectum and sigmoid because they are more distal, but small bowel we can see 2 to 3 distended lobes of a small bowel because it is adjacent to this ileum, and because the large bowel is more far away from the ileum, air in rectum or sigmoid can be visualized. But the near segments like to the ileum, like the cecum and ascending colon and transverse, there is no air within this small air because non-functional part of the ileum. In generalized ileus, we can also visualize air, normal air in rectum or sigmoid with multiple distended lobes more than 2 to 3 of a small bowel and air in large bowel. Also, we can find distension in small bowel obstruction because the air first cross the small bowel and going then to large bowel. In cases of small bowel obstruction, there will no normal air passage from small to large. So we will not find normal air in rectum or sigmoid or either in the rest of large bowel. If we could visualize air in the small bowel, it will be multiple dilated lobes more than 3 centimeters of a small bowel proximal to the obstruction. In cases of large bowel obstruction, the distal portion of the large bowel is the sigmoid and rectum, where there is no gas normally seen there in cases of large bowel obstruction. And the rest of large bowel, it must be dilated according to the rule 369. 3 stand for small bowel, 6, as we said before, the rest of large bowel, and 9 for the second. In large bowel obstruction, if we look at the radiograph at the center to look for small bowel assessment, none unless ileocecal valve incompetent. We shouldn't see any air in small bowel unless the ileocecal valve is involved. This is the finding in small bowel obstruction and large bowel obstruction and IES. Localized IES key features: 1 or 2 persistently dilated lobe of large or small bowel can be visualized, gas in middle or sigmoid. We have sentinel lobes. This part of the image showing the sentinel lobe, the part of the IES lost its innervation, which is dilated and filled with gas. Sentinel lobes in appendicitis, we can visualize it over here. Cholecystitis in the right upper quadrant, pancreatitis ulcer in the left upper quadrant, diverticulitis in left lower quadrant, and periumbilical in the ulcer in cases of ureteral calculus or renal stone, in other words. Localized IES it forms very simple early mechanical small bowel obstruction. In cases of IES showing clinical, we have to follow the clinical course and get follow-up for the patient, because the ileum is a part of small bowel, so it can resemble small bowel obstruction. In cases of generalized IES, gas in dilated small bowel and large bowel to rectum distribution, long air fluid levels, only postoperative patient have generalized IES. So generalized IES will be suspected in patients who undergo surgeries. Generalized adynamic hernias, for example, here postoperative patient like after appendicitis, appendectomy operation, we can find like here, this is a long air fluid level in the small bowel because it is in the center. This is air fluid level, and this is also lower multiple air fluid levels, denoting generalized IES. Here, the stitches on the previous surgery of the sutures. It is an IES. This is the question. If the patient immediately was operated, are the bowel sound absolute or hypoactive? If no, then it isn't an IES. So clinically, we should answer these questions first before diagnosis. Isn't it an IES or no? Because we need to correlate it clinically. Patients do not present to the emergency room with a generalized dynamic IES, because this patient will be admitted with us in the hospital after operation. Regarding small bowel obstruction, mechanical small bowel obstruction, we can find dilated small bowel, fart loops, leaking gas in colon, especially the rectum, very little. The key imaging feature is proportionate dilatation of small bowel. Here, the button of valvular convolutions. This is the valvular convolutions of the, which is characteristic for small bowel, not like the fistula of the colon. This is the fistula of the colon, which is wide arches in the colon. But the valvulical contains is very tiny fistula of the colon. This is the fistula of the colon, which is wide arches in the colon. But the valvulical contains is very tiny button within the small bowel mucosa. But here, because it is mechanical small bowel obstruction, we can see this part of small bowel is dilated most probably more than 3 centimeters. So it denotes or denoting there is a small bowel obstruction. Mechanical small bowel obstruction can be due to adhesions from previous surgeries, hernias, volvulus, gallstone hernias, intussusception, especially in pediatrics. So these are the causes of small bowel obstruction. Adhesions from previous surgeries, because when patients undergo multiple and different surgeries, some areas in the normal healing process can lead to adhesions or fibrosis within the site of surgery. These adhesions can result in complication like small bowel obstruction post-operatively. It can be in months or in years. Hernia, because hernial orifice, like in inguinal hernia, can undergo strangulation or being a cause of mechanical small or large bowel obstruction. Volvulus, which is an LT1. We have the commonest sigmoid volvulus in elderly men and cecal volvulus. According to the anatomical location, either the volvulus was in the cecum or in the sigmoid, or in pediatric, the mid volvulus, and some cases of malrotation, which is a congenital abnormalities. Gallstone hernias, when a gallbladder stone descends to the ileum, it can cause a small bowel obstruction. In this case, we can find pneumonia, which is presence of air in the biliary tree, intrahepatic biliary tree. This is the case of gallstone hernias. In cases of intussusception are the cases where part of small bowel intervene in other normal part of the small bowel. This is the cases in intussusception, which are common in pediatric population more. Here we have mechanical small bowel obstruction. Early small bowel obstruction, they resemble localized hernias, should get follow-up. This is an early image because here we have absent air within the distal small bowel lobes, but the presence of air normally in the proximal bowel lobes. Dilated colon to point of obstruction also can be a sign. Little or no air in rectum or sigmoid, little or no gas in small bowel if ileocecal valve remain competent. Here, for example, we have a distal or lateral gas distribution and smooth and loss of aspiration of the large colon. This is large bowel obstruction. This is a supine view where the patient is standing upward, and this is a broad where patient lying in his back. Mechanical large bowel obstruction can be due to different causes like tumors, like colon cancer or rectal cancer, for example, volvulus, been mentioned previously, throughout, as sigmoid volvulus or cecal volvulus, hernia, inguinal hernia, epigastric hernia, or any type of hernia. Diverticulitis. Diverticular means outbouching of normal colon. This diverticular can be normal finding, but sometimes it can have some type of itis, which is an inflammation. Then we have intussusception, as we mentioned previously, in the pediatric population, which is common. These are the causes of large bowel obstruction: tumors, volvulus, hernias, diverticulitis, and intussusception. And the commonest site for diverticulitis is the sigmoid colon. In cases of large bowel obstruction, in cases of incompetent ileocecal bowel, that means the air within the colon can obscure to the small bowel. Large bowel decompression into small bowel, so we can have both small bowel and large bowel dilatation, may look like small bowel obstruction. Here we have to get perium enema or follow-up. In such cases where there is incompetent ileocecal bowel. Carcinoma of sigmoid colon, there is carcinoma over here. This is the sigmoid colon anatomical position. We have incompetent ileocecal bowel, so the air from the large bowel periphery, this is the ascending and the cecum, and the air escape to small bowel, because we have the difference between small bowel and large bowel. We have, as we have said before, the large bowel have aspiration. This is the history of the large bowel. But this tiny are the umbilical events, which is the Neapolitan method, different between the large bowel, which is located peripherally, and the central located small bowel. Here we have incompetent ileocecal valve. Ileocecal valve is a valve between the ileum and cecum. Over here, the right iliac fossa. Moving to the next. Here, repetition of small bowel obstruction and large bowel obstruction and refinement, as we said before. We have some cases antmeaning. When we say antmeaning, we mean a known person whose name antmeaning. This grandmother called antmeaning. So if we have a known case like a small bowel obstruction, large bowel obstruction, we call this is an antmeaning. Antmeaning as we know it before. It's just a name. Like here, what do you expect to see? As we have said before, this is a gallstone iris because we have this stone over here. This is a gallbladder stone, which is descending to the ileum, and this is right upper quadrant image. This is the liver margins, and this is the gallbladder underneath. So in this case of gallstone iris, we have dilatation of small bowel due to small bowel obstruction due to the presence of the stone, and pneumopilia, which is presence of air within the biliary tree, the CBD and cystic duct and the intrahepatic biliary. This is gallstone iris. Here air will be near 3. This is the gallstone. This called regular triad, which is diagnostic for gallstone iris. Regarding this image, we have soft tissue mass over here because the density over here isn't the normal density of bowel or large or common or large bowel. So this mass over here causes obstruction and dilatation of proximal colon or large bowel obstruction due to colon cancer, for example. And the females could be due to fibroid, for example. And here we have the midline sutures, dilated small and large bowel displaced from the pelvis. Post-operative C-section, a dynamic iris. This is the case. A dynamic iris due to post-operative. So in this case, this is generalized iris because we have said that generalized iris can be due to post-operative cases, like in this patient. Moving to next. Here we have dilated large bowel. What else? If you notice here, the largest portion of the colon dilated in the anatomical position of the sigmoid colon. And the sigmoid colon in an elderly male patient is common to have volvulus or mean intima. So it gives this dilated side originating from the left lower quadrant. So this is the axis of rotation of sigmoid volvulus. In this image, dilatation of the bowel over here and also the presence of dilated bowel loops, So this is due to bowel ischemia, acute bowel ischemia, or mesenteric occlusion due to acute bowel ischemia because of presence of embolism or blood clot within the vessels that evacuate nutrition, giving the blood supply to the stomach and the bowel, small and large bowel, like the celiac trunk and superior mesenteric artery and inferior mesenteric artery, the blood supply for the GRT. Abnormal gas pattern in this or IBS and obstruction. We have two localized IBS, generalized IBS. This is the two types of IBS: mechanical small bowel obstruction and mechanical large bowel obstruction. Now we are moving to the extraluminal air, free intraperitoneal air. Besides the presence of free air under diaphragm, both sides of bowel wall, this is a sign called hematosis intestinalis, the presence of the air within the bowel wall itself. Falciform ligament sign, because falciform is adjacent to the liver. Sometimes, if there is free air, it can be trapped under it with the depression of falciform ligament. Here, this is free air under diaphragm within this crescent shape, and here free intraperitoneal air also between the bowel loops. And we have also this sign called, which is called featureless abdomen. Featureless abdomen means there is no or absence of the normal gas pattern between the different organs. So the abdomen is a bit like a single image without any lines between its organ. This is the case of free intraperitoneal air suspected viscous perforation. Here we have air import, which is called regular sign, the presence of air inside, normally inside. Here we have the stomach, this is the small curvature, and this is the greater curvature. Here the fundus of the stomach, here the body of the stomach, and this is the pylorus or pyloric canal toward the duodenum. Over here we have the normal air within the stomach and the abnormal air outside the stomach, giving this line of mucosa because of the contrast from the air inside and outside, which is abnormal. Air on both sides of bowel wall or stomach wall, in this case, form regular sign. We also can appreciate regular sign. Cases of intraperitoneal air. The case of free intraperitoneal air. Here we have the sign of falciform ligament, which have been mentioned previously. The presence of air surrounding inside, in the both sides of the falciform ligament. It is projecting from the liver ileum. Here we have football sign, which is the presence of free air as a ball inside the abdomen. Cases of free intraperitoneal air. This is the football sign. Okay. Presence of air surrounding the bowel obstruction structures or abdominal structures. Free air, causes of free air in the diaphragm. Rupture of hollow viscous, like perforated ulcer, like gastric ulcer or duodenal ulcer. Perforated diverticulitis. We have downbouching from the colon called diverticulum. If this diverticulum get some type of inflammatory process or infection, it's called then diverticulitis. This diverticulum can also be perforated. Looks like the perforated appendix, which is not written here. Perforated appendix can undergo the same process. After inflammation, the wall is sent out and then it can perforate. Perforation of carcinoma or due to carcinoma, perforation post intestinal obstruction. This is why in cases of small bowel obstruction and large bowel obstruction, we have to refer the patient to the surgical team to repair the intestinal obstruction, because sometimes the intestinal obstruction can lead to perforation of hollow viscous. Trauma also, if penetration of the bowel, care or iatrogenic in cases of operations, instrumentations can cause rupture of hollow viscous in iatrogenic way. Free air under the diaphragm sometimes can be normally after operations. In post-op period from 5 to 7 days, it is normally. Then it will absorb normally by the body. Not perforated appendix also can appear with free air. Here we have free air. The lesser sac in this area, making a triangular shape between the lesser sac and the retroperitoneum. Here, the air in lesser sac. In this image, this free air in extraperitoneal imposition due to bladder rupture in cases of pelvic trauma or pelvic fracture can lead to rupture of urinary bladder. Urinary bladder, there is no intraperitoneal air, but there is extraperitoneal air lining the pelvic muscles. This is extraperitoneal free air. Sometimes, because the bladder has both portion, the lower portion of the bladder, urinary bladder, is extraperitoneal, and the upper or posterior is intraperitoneal. So the bladder have the both extraperitoneal rupture and intraperitoneal type of rupture. Intermission, there is no such thing as a non-specific gas pattern. It is either normal or abnormal, always in the image. Adynamic ileus is overcalled sometimes, only occur in post-operative patient, which is the generalized ileus type. Take note from this lecture. Moving to soft tissue masses, we have hepatosplenomegaly when we can see large liver shadow and spleen shadow. Hepatosplenomegaly can appear in plain film, but it is poor for judging liver size. It's better to do it through ultrasound or CT. Tumor or cyst as type of soft tissue masses. Tumor are soft tissue and cysts are fluid-filled structures, abnormally situated, but some part of cysts are physiological types, like ovarian, for example. Bowel displacement can be also a sign for soft tissue masses, because if there is a pelvic large soft tissue mass, it can displace the adjacent bowel loops upward, which can be a sign to diagnose soft tissue masses from a radiograph. We can notice that thrombosity of gas, bad sign, extrinsic compression of the bowel lead to bad sign by the soft tissue mass. Here, for example, we have some surgical stitches in the side of gallbladder underneath the liver. This is the side of gallbladder. But if we notice the spleen over here, this is the stomach, and lateral to the stomach we have the spleen. This all is the spleen. So this is case of splenomegaly from a radiograph. In this case, we have an opacification within the center of the abdomen due to myomatous uterus. This is fibroid in the uterus with calcification in some areas of it. This large fibroid causing displacement of the normal distribution of gas pattern in the bowel upward. The next case, here we have the normal pattern of the small bowel, and here we have the displaced bowel upward due to pelvic mass. Here, bladder outlet obstruction. The pelvic mass in nature was bladder due to bladder outlet obstruction in cases of BPH, benign prostatic hyperplasia, for example, if it is a male patient. And this is a pre-operative, and this is post-operative after the release of obstruction, and the displaced bowel went back to the normal side. Another case over here, you can notice there is a mass located in the left upper quadrant, mass in hologastric space. It appears as pancreatic pseudocyst because here the spleen, and here the stomach, and here the transverse colon, and here is the pancreatic normal anatomical location. So this is pancreatic pseudocyst from the image, specifically in the tail of pancreas. Over here, we can notice there is a mass in the right upper quadrant. We perform a CT scan for the patient, and we find out this mass was previously noted in the radiograph is situated over here. This mass is not an adrenal because this is the adrenal gland normal CT scan. So this is a right renal cyst because this is the left kidney and this is the right kidney, which is arising from the right kidney adjacent to the liver. If you notice, this is the outline between the liver and the right kidney. Here, the previous signs of somewhat featureless abdomen between different organs. There is some loss of buttons or the outlines. Here we have some collection in the right lower quadrant, as previously noted over here. This collection, because of the button of enhancement that we take contrast surrounding the collection, we find out this is a right lower quadrant abscess. The abnormality in this image is focusing on the pelvis. If you focus, there is increased opacification in this area via the side of urinary bladder in the pelvis. This looks like ears. It looks like the gallbladder has got ears. This is a sign of free peritoneal fluid bladder ears sign. We have abdominal calcification. Last topic for today. The buttons of abdominal calcification can be ring-like, linear or trace-like, lamellar, cloud-like. Ring-like calcification, wall of hollow viscous like cyst and renal-like renal cyst, aneurysms like aortic aneurysm, which is the indication of the aorta, circular organs like gallbladder, also gallbladder wall can be calcified, or porcelain gallbladder because the calcification within its wall. Here we have renal cyst with calcified ring-like calcification. Here also we have gallbladder, porcelain gallbladder underneath the liver in the right upper quadrant, linear or trace-like walls of tube like ureters, for example, arterial wall in cases of atherosclerosis due to presence of calcification within the vessel wall. This is cases of atherosclerosis, which is suspected normal finding with aging. Here, calcification within in a normal base difference in a male patient. Lamellar or laminar type of calcification formed in lumen of hollow viscous. Lamellar come from lumen like in renal stones, bone stones, and gallbladder stones, which is accumulation of calcium stones within the holobiscus. For example, this is in urinary bladder. This is urinary bladder calcification. Here in the pelvis of the kidney, which is called staghorn calcification or stone in urethrucine, staghorn calculi in the renal pelvis, and it looks like bilaterally. Cloud-like amorphous or compound type of calcifications and different type of calcification formed in a solid organ or tumor, like the fibroid of the uterus or the other name myomas of the uterus, ovarian cyst adenomas, which type of ovarian adenomas. Here we have nephrocalcinosis, the presence of calcification within the medulla of the kidneys bilaterally, and it's drawing the shape of the kidneys in a radiograph. And here the classification of the pelvic fibroid or myomas, nephrocalcinomas, and myomatous disease of the uterus. Some types are unknown, like for example here, this can be contrast material if the patient have IV contrast study, like CT abdomen with IV contrast, and we image the patient after many hours, we can find the presence of contrast fluid level. This is the urine in the urinary bladder, and this is the contrast sedimentating over here, and this is the line of the ureter or the urinary bladder. Is it the right? This is right. Here we have some calcification in a mass within the pelvis, which is like a popcorn. This is called Jackstone calculus. Looks like a star. Here, calcification within the pancreas in cases of chronic pancreatitis. Calcific pancreatitis in chronic pancreatitis cases. Here, pelvic calcification due to prosthetic calcification within the prostate gland in a male patient. Here, calcified renal cyst in right kidney. Here, porcelain, gallbladder wall is calcified. Radiograph. Now we came to the end of our lecture. You have to examine in an abdominal radiograph the normal gas button and abnormal gas button, extraluminal airs, either it is intraperitoneal or extraperitoneal, soft tissue masses, and calcification. So we came to the end of our session. Thank you all for your